Welcome to our panel on Cancer Care for All, expanding access to life-saving treatments in Africa. Cancer is an escalating public health challenge with limited access to early diagnosis, radiation therapy, and essential treatments driving high mortality rates. Women are disproportionately affected, particularly by breast and cervical cancer. Today, our panel of leading experts from the IAEA, international organizations, and African countries will explore the barriers to cancer care, such as technology gaps, financial constraints, and workforce shortages, and highlight innovative solutions to expanding access to life-saving treatments for all. We will open the floor for questions after all the speakers have delivered their initial remarks. For those in person, take note of your questions, and when the floor is open, please wait for the microphone to reach you before asking your questions. For those online, you may submit your questions at any time using the Q&A function. Please note that at the end of the event, we will circulate an evaluation form, both in person and virtually via link, and we would appreciate it if you could take a couple of minutes to fill out and provide feedback. These forms are all anonymous. This event is also being recorded and will be available as part of the web post after the event on our website. So I want to turn first to Dr. May Abdel-Wahab, and she is currently the director of the Division of Human Health at the International Atomic Energy Agency in Vienna. She has over 30 years of patient care, teaching, and research experience in the field of radiation medicine. Before joining the IAEA, Dr. Wahab was section head of GI radiation oncology at the Cleveland Clinic and a professor of Case Western University. She served on national and international committees, advisory boards, and journal editorial boards. A fellow of the American Board of Radiology, she has also been listed among the best doctors in Africa. In addition, she has an interest in healthcare access and training, as well as novel solutions to address disparity and diversity issues. May.
Well, thank you very much for the invitation to be here with this wonderful group and to talk a little bit about life-saving therapy. So this is very descriptive. If you compare both of these maps, you'll see that they look almost the same. And basically, this is an HDI map, or Human Development Index, which tells us about the education, and the advances and the resources that people have, and the quality of life. And the other one is the mortality, premature mortality from cancer. So this speaks louder than words. But it's not only about money. There are other things that we have to consider when we're talking about this. One is, of course, the healthcare infrastructure and workforce capacity, which we've heard a lot about, setting up centers, training people, and so forth. But it's not in a vacuum. We have to think about the financing mechanisms, not only of the center, but also for maintenance, and also for patient being able to access the center and how much they have to pay out of pocket. Then you have referral systems. Will they ever make it to the center? Then you have quality assurance, because if you don't have good quality treatment, good quality diagnosis, then we've really lost the battle. So the Lancet Oncology Commission, which many of you may be familiar with, looked at radiotherapy and diagnostics and showed us that there was a deficit and an inequity in terms of availability of radiotherapy machines. The previous one in diagnostic imaging showed the same thing in imaging. And here on the right-hand side, you can see, very interesting, that in sub-Saharan Africa, for example, there has been an improvement, slight, but there. And the main change, the biggest change, is that we went from cobalt to Linux in many of the cases. However, we still need 8 times the number of machines in low-income countries to reach our goal of 1 machine for 500 patients. And not only that, we need to increase our workforce by 60%. And I'll mention that again. A lot of challenges. But just to put things in perspective, these are 2 articles that were prepared approximately 10 years apart. And what we see here is there is an improvement. It was 12% of MV units per million, or the Linux, for example, and cobalt per million. But the cancer cases went up 32%. So you can see we're playing catch up. even though we are working and we're making progress. So it's a hopeful message, but we need to make it faster. Here we see the investment of equipment, for example, and we see that the biggest investment is going to be in Asia Pacific because of the population. But here in Africa, you can see that there is a significant investment. And if we look at a percentage of what's available, it's almost double that needs to be done. But does it make sense? We're not talking to just the humanitarian perspective. We're talking about the economic perspective as well. So here on the left-hand side, you can see that if we scale up imaging treatment with good quality, then we can invest about 230 billion. Sounds like a lot, but we spend much more in things that are not directly helpful to human beings. And then we get a net benefit of $2.6 trillion. Now, if anybody's investing, that's a good investment. So the main challenge is 26 countries, and we have our colleague here who put this together. And you can see that there are many challenges, and all these check marks means that these challenges are found in these countries. Very interesting. So the two that we're very familiar with, equipment, lack of radiotherapy, and lack of maintenance or spare parts, and high cost of maintenance, all of that, we understand that. But then the limited training opportunities are extremely important, because how are we going to, where's the pipeline that's going to give us all these extra people who are going to run these centers? And then lack of specialty recognition, which is a big issue, because for any professional, if they want to move forward in a career, they need to be recognized as a specialist in an area. This is especially problematic in medical physics, but in other areas as well. This is the most important slide. 200% increase in number of people or additional staff in all aspects of radiotherapy, whether it's radiation oncologists, medical physicists, RTTs, dosimeters, all of them, we need to increase by 200%. That's pretty significant. How are we going to do that? The other issue is, over the last 10 to 20 years, the length of training has increased from 3 years, which was standard, to 4 years to 5 years. And the effect of this is extremely important. So as you can see here, this green line is the nominal amount that we would need. And then this one is the optimal amount up here. Down here, we see the number of years of training. So if you train for 5 years, for example, you will never, if you train for 5 years, you will never make that nominal green. You will never have enough people. If you train for 4 years, you will, but it'll take you a long time. If you do 3 years training, then you'll not only get to the nominal, but get to the optimal. And that's really important. It means that we need to train people better rather than keeping them sitting there training for 5 years. We need to do better. We used to train in 3 years. Now it's 5. Why is that happening? So this is about the IAEA. So our human health program, we have the different specialties that cover radiation medicine. That's our area of expertise. So whether it's medical physics and dosimetry, we have a dosimetry lab in Cybersdorf as well, whether it's radiation biology and radiotherapy, nuclear medicine, diagnostic imaging, and we have colleagues here from the group, and nutrition as well. We do everything from setting up centers around the world and training people and developing guidelines, doing research, improving quality, services, and safety, and also partnerships, of course. We work through CRPs, TC projects, collaborating centers, and informal advisory groups. So here, the first thing you want to know, what are the needs? Because you can't have a plan that works without knowing what the needs are. And this is an example of some of the databases that we have. And as you can see, it has a lot of information and very useful. Dirac, Imagine, others. Here we have the research opportunities. Why are these important? For 2 reasons. First of all, you have to do things better, resource sparing, using the machine better. You have to do better quality and better techniques to be able to address quality. And also, you have to be able to plan, where you're going to put the services and so forth. Education and training is important, whether it's guidelines and publications, whether it's online tumor boards and many others. And I'll give some examples. I'll try to move quickly. Quality assurance, we have many opportunities in that area. Radiation safety, of course, and access, setting up centers. Okay, this is an example of the guidance document. Someone wants to set up a center. You have everything from setting up a program, a radiotherapy program, to radiotherapy facilities master planning, design, all the way to sustainable management of facilities, which is a big point, and technical specifications to help people choose the right machines. And then within a cancer center, we have the setting up of a cancer center, comprehensive cancer center, which has radiotherapy, imaging, and everything. So we have a full suite of opportunities. Oh, and also the curricula. So everything's available online for free. Our e-learning resources also include full curricula like this, but also interactive e-learning modules, videos, micro-learning, multimedia, and webinars. So many things, and of course, tumor boards where doctors can talk about, patients and present them and get opinions from other doctors. This is an example of planning, very important. So we can look where the population is. We can decide where to put in the cancer center or the center, and that way reach a larger population. So again, efficiency. Quality assurance, we have three main factors. The first is directly to hospitals. We send them dosimetry audits to check their beams. The second one is to be the center of a network of secondary standard dosimetry labs that then go and help hospitals make sure that they're giving the right doses. And the third is methodology for auditing. And that's extremely important. And we train the trainers so that they can do it in their own countries. All of these things are important. And the impact you can see here, 39 countries in this one, 144 countries in this one, large numbers of countries and centers that are being helped. So now I'll quickly go through Rays of Hope. Many of you have heard of Rays of Hope. Basically, very simply, it's three main pillars. The first pillar is supporting access through technical assessment and economic evaluations, like the things that we do, like the databases that I showed you and so forth, or any information from missions, and capacity building, training the people, the standard stuff. So what's new? We've been doing this for years. The difference is the scope. We're doing more. Over 90 countries, 93 at this point, have asked for support. The second pillar is sustainability. And all of us who've worked in this field know how important this is. So with sustainability, we do it through our anchor centers. They're regional centers that undergo a pretty significant auditing kind of process of evaluation. And once they're found suitable, then they can sign, they go through a committee, and then they can sign and become an anchor center. And I'll talk a little bit about that. Then the third pillar is innovation through research. I talked about that, but in addition, also having a database to look at impact. Are we making an impact when we do all these things? So this is just a few examples of progress to date. We have here in Africa, buying equipment, constructing radiotherapy centers, and training professionals in all of these countries. In Malawi, it was the first public radiotherapy center that's going to be open soon. Here in Latin America, we have the same kind of thing, where procurement of equipment, training of people, and so forth. And an example for breast cancer, the mammography equipment in Latin America. It's going to be in 18 countries that we're providing this with training. So these are the anchor centers. This is the hope that we have for sustainability for all the work that we're doing. And you can see that they're scattered all over the world in different regions. In Africa, we have 3, and we have 1 that's been approved but has not signed yet. So not only are they supposed to be supported themselves in terms of education and otherwise, just to go to the next level, because they're already at a very high level, but they're already giving. And these are examples of some of the regional workshops and training that have been happening already in theranostics, in pediatric radiation oncology, and other things. And these anchor centers have had, many of them, as you can see here, have had already had expert missions to look at if there are any areas that could be areas of opportunity for us to improve, and to develop a joint work plan. This is the third pillar, which is the database that we're talking about. And the reason this is important is for several things. First, it can guide policy. Second, it could show us whether what we're doing has an impact on patients, because we can get patient data. And third, it can look at health economics and see what we're spending on this and how we can plan better. So it can help the ministries of health and finance in the country. But that's not the whole story. We have some additional factors that we need to address. Simple things like interim housing for traveling patients. For many people, they can't afford to leave their home and pay for a hotel or stay in the street. I mean, you have to think of the social issues that are barriers to the patient moving forward and coming in for treatment. And then increase education of the community to know, yes, I feel a breast mass, I need to go in and see what I can do about it. And then using virtual visits. So they can come for the treatment, but do they have to come for every follow-up? Maybe we can do it online. Everybody has mobile phones, even in the poorest regions. Maybe we can do better. Here we have the geographic access. Even if a country has enough Linux, doesn't mean the population can still access. We have that in high-income countries as well. We've published in Canada and the US and other places where geographic access is a barrier. And that could be even more in other countries. We have financial access. I talked about that earlier. We have social support. What if their family can help them, but what else? Is there a navigator? Is there a social worker? All of that stuff. And of course, medical literacy, that they understand what it means. If you have cervical cancer and you're going to disappear from the treatment, then you have to understand that your chance of cure is extremely low, even if you come back, because you have a gap. And that applies, by the way, to a machine being, not working, because, every week you're going to get a certain percentage less control of the tumor. If it's long enough, then you're not going to get control of the tumor at all. Okay, so factors increasing likelihood of seeking care. If you know about cancer, obviously, just like all of us, when we have experience, personal experience, we understand a family history, for example. If you have a strong support system that's going to take you to the hospital, certain religious beliefs in this paper, and then factors decreasing the likelihood if you lack awareness of cancer or education. So that's why these initiatives with many of the NGOs to increase literacy is important. Lack of health-seeking behaviors from the beginning, so they have symptoms, but they avoid it. Presence of traditional religious healers sometimes, instead of going to a regular medical facility. I mean, they could, in some cases, it could be complementary, could help in many ways, but shouldn't be done alone. And then stigma is a big thing. I mean, I remember I had a patient once who told me, I'm not going to get treatment, I'm going to die anyway. I said, why? He said, I got this because it's bad blood. And that was the first time I ever heard of that. And I was like, what does that mean? So some people think that it's like sins they did that caused this or something like that. And for children, they said, oh, it's the parents' sin. So you can't, it's difficult to explain. Fear of treatment for many reasons, radiation burns, whatever. Low socioeconomic status for all the things that I said, and a challenging referral system. But it's not hopeless. We can do it. There's so many things we can do. And we have the tools to do it. We just have to come together and work together and do it together. Thank you very much.
Thank you so much, Meg. I just want to, if you could just quickly explain what theranostics is for the people who who aren't medical experts.
Of course. So theranostics is using diagnostic imaging, using radionuclides to find where the tumor is, but then having radionuclides that can then go to this tumor and treat it at the same time. So it's very attractive. The biggest use of theranostics is, the most exciting future use is prostate cancer, where there's a lot of very interesting studies that showed that if you give it, even in end stage cases where people think that there's nothing else to do, they've failed everything there is to give, and they have it, and then it could clear up a lot of these metastases. So that's really the next kind of exciting area that we're going through. There are older kind of theranostics, which is like iodine treatments, where we can diagnose where everything is and treat at the same time. But right now, the excitement is because of this prostate cancer lutetium that's come up, where we can see where the tumor is and also treat it.
Thank you so much. Okay, we'll turn now to Professor Manjit Dosanjh, and she is a former senior advisor for medical applications at CERN. You want to consider? Okay. and is now serving as a visiting professor at the University of Oxford and project leader for STELLA, which she will be talking about, smart technologies to extend lives for linear accelerators. She's also on the board of the ICEC, or the International Cancer Experts Pool. She has over 30 years of experience in medical applications, holding positions in institutions such as MIT, the Lawrence Berkeley National Laboratory, and the European Commission Joint Research Center. At CERN, she applied particle physics technologies to life sciences and advanced cancer treatment, focusing on establishing multidisciplinary collaborative approaches for cancer treatment, expanding access in low and middle income countries. Her work has included many initiatives to expand access to technologies in low middle income countries, and she is the project leader of Project STELLA. Great.
Thank you, Ingrid. Thank you, May. Good morning, afternoon, evening, depending on where you are listening. And, you know, May is a hard act to follow because she's got this big global perspective. And of course, you're very lucky that you have IAEA right next door to you. But I'll tell you a little bit about what we are trying to do in our window. And the thing is, May's already pointed this out. You know, it's radiation therapy, which most people don't necessarily know, is one of the most useful tools for cancer cure and pain relief. There's inadequate supply of machines, which has been pointed out. The gap, unfortunately, is the greatest in low middle income countries, but not only. As has been pointed out, coming from the UK is a high income country. We know all about radiation. We think we know everything. But the recent studies that have been carried out shows, unfortunately, that in UK, like a lot of other high income countries, US, for example, the rural regions have as many challenges to having access as some of our LMIC counterparts. And you know, how do you try to address these challenges so that this idea that only 10% of the patients in low income countries have access? It's ridiculous in this day and age that we should have such a disparities. And you know, you, as already been pointed out, cannot deliver high quality cancer without well-trained, adequate workforce. And that's a challenge everywhere. So we have to think of new ideas. How do you meet the challenges of providing sufficient workforce from not only oncologists, RTTs, medical physicists, all of these, and everywhere you look, and I'll show you a couple of charts, that there's a shortage everywhere. And then, of course, if you don't know, first, if you don't know about cancer, and then if you don't know if you have cancer, you don't have an imaging equipment, you can't have treatment. So it's a really multifaceted challenge. And here, thanks to the IAEA, this map in 2012, which is what has triggered the new dialogue that we've been working on for the last 10, 12 years, because it was shocking for me when I saw this, that only the green countries here had sufficient access. And then you can see where all the dark red are. And the reason I put this map is because that's really the first time it really raised awareness. But secondly, it was this map which got ICEC, the NGO I work with, International Cancer Expert Corps, which was established by Norman Coleman, who was really the founding father of this. He came with this map to CERN, which is the home of technology. You know, we are the cutting edge technology and so on. And I look at this, and when Norm presented this, we had a couple of very smart accelerator physicists in the room. He said, how is it possible that you have these challenges? And one of them is Ugo Maldi, who's 90 now. He's the son of our founder director of CERN. And basically, that's how we got involved in ICEC. And you've seen this, but you see, the thing is, yes, there are some changes, but the disparities, unfortunately, are still there. So obviously, we have to do something differently. It may be not something, many things differently, okay? And then as I was saying, that if you don't have imaging, then you have the same situation because you can't treat if you don't know you have cancer. And we talk about CTs, we talk about diagnostics, we talk about MRI, PET, all of these things. And of course, you need money, you need expert workforce, and then you need to be able to use it appropriately. And there are many places that are lacking. And then talking about disparities, so here's a map showing the access to oncologists. You see similar trends, unfortunately. And then recently the paper coming out from the Lancet Oncology showing that globally we are 18 million short. And then a third of that is in Africa. And 80% of the population in LMICs is without access to trained oncology providers. That's just incredible to even think about, okay? And then, of course, I'm going to focus on Africa, and then Taofeeq will follow, will talk about Nigeria and focusing even more, because that's what I've been working on the Baltics, the Balkans, the former Soviet Union countries, but this is the continent that's really, when you see the fact that, I think, oh, is there it doesn't matter, okay? The fact is that US, sorry, oh dear, don't touch. Don't touch. You see, technology is wonderful when you know how to use it. So just to say, Africa is a continent of 1.4 billion people, has 400 machines, 409, okay, changes 1 or 2, but it's a trickle effect. But when you look at the US, it's a country of 340 million, 4,000 machines. But the sad part is, even though the US has a huge number of machines, we are doing a study as part of ICEC, our NGO, that if you look at somewhere like even Texas, which has a huge number of machines, but there's a large part of Texas that has no access. So there are some bigger challenges we have to deal with. So, you know, and of course I live next to Switzerland, and I'm very lucky because it has so many machines, so many detectors, so much staff. And of course you pay for it, but it's a small country, right? So, and by 2030, 1.4 million new cases of cancer, 1 million cancer deaths in Africa. And really, when we started some of the studies, it was 28 countries, and it looks really, okay, there are machines, but the sad part is 60% of them are in 3 countries only. So you are really, you know, this challenge. And there's so many countries having no machines. So, and I just wanted to touch on what Ingrid mentioned, a study carried out by Sylvia Fomenti's lab. She's one of the board of directors of ICEC, carried out, showing that 7 out of 10 breast cancer deaths, 9 out of 10 cervical cancer deaths occur in LMICs. This is horrendous now because we think we know how to tackle breast cancer and with cervical cancer with vaccines, but that's going to take 20, 30 years before it comes through if you can convince people that it's a good idea to have, right? And then associated with this is that for every 100 women that die, 40 to 20 children die because they don't have the care, attention that they need. So this problem is really, really tough. So Project STELLA, which been working on ever since Norm presented in a conference in 2014 in Geneva, is, you know, expanding access to high quality cancer care globally, developing an innovative transformational radiation therapy system, because we realize the current methods is something is not quite working and meeting the challenges, driving down the cost, of course, and cancer care, and they go hand in hand, and the enhanced training, education, and mentoring network for really trying to implement that. And we started with the STELLA collaboration because, you know, coming from CERN, this large hadron collider you might have heard of, or the, you know, the Higgs boson, which is this amazing particle, but you wouldn't know it if you hit it, right? It's invisible, okay? And you know, what we are really excelling at CERN is we know how to collaborate, because there's only one LHC, because we can't afford many of them. So we are forced to collaborate, discuss, think of ideas and brainstorm. And so then when Norm Coleman came to us, we said, okay, we are going to do it the CERN way. So we had the very first meeting in 2016 at CERN, really brainstorming with everybody around. And then we've spent some time building, enhancing the collaborative system and network. Because the other thing that's really obvious to me is that we can talk about all these numbers. It's only when you experience it do you realize what the challenge is. So when we had the meeting in Gaborone in Botswana, some of my colleagues from CERN, couldn't believe it, that, you know, we had 2 centers, and you were there, of course, Taofeeq, that we had a private center which still wasn't coming into operation or was state of the art. And there was the public center. There were people just sitting in corridors. And it's just, I don't understand, okay? It's just don't understand. So what we did was, seeing this challenge, because, you know, we are a fact-based organization. CERN is all about understanding what's going on. So we actually, with the help of Taofeeq and his colleagues, we looked at all of the African countries at that time that had radiation therapy and trying to see, and then, you know, what were the challenges? What do they think? Because from the grassroots, because, you know, it's really important, sitting also in Geneva with all the UN entities where I do a lot of NGO work, that the LMICs don't just have the challenges, they have the answers for the challenges. They have to come from them, because that's the only way to address it, is if you communicate with them. And so, and then we compared with high-income countries, and we actually looked at around 100 LINACs. And what we found many things. But the sad thing is, of course, economics have a lot to do with it, okay? It's obvious that Switzerland, US, UK, Canada are there. And then we have our countries which have the least resources. And yes, okay, there. But, you know, the thing that really was even sadder for me is not only they don't have enough LINACs, but the LINACs are always breaking down. So you don't have the machines and then they don't work. So what is it that we're going to do? And this map, you know, in Madagascar, which was down, what, 30 to 40 weeks? And they had a wonderful machine. They had a service contract, but they needed to have a part. But they could not order the part because they had to pay for it first, and then the insurance will compensate for it. I mean, there is no room for things like this, really. And May has referred to this. So we looked at which are the biggest challenges of making these machines running and high patient throughput. So we, amazingly enough, power issues, infrastructures, of course, software issues, but access to spare parts. Who would think having access to spare part was a challenge to keep the machine going? So, you know, so these are some of the things we were looking at. And then, you know, on the right is how quickly, when something goes down, can you repair it? And that, once again, high-income countries have the access. And, you know, and the sub-Saharan Africa region has the biggest challenge of repairing because they don't have engineers, they don't have expertise, the spare parts are miles away. And you will have heard this very sad story in COVID when this young woman from Zimbabwe who had breast cancer, and she was trying to say, what happens if you don't get treatment for 3 weeks or 4 weeks? Well, people didn't know because it doesn't happen. Okay, so what STELLA is looking at is we are trying to reduce the cost of the radiation gray per day, okay, reducing the head count of specialists per LINACs. This is kind of really where our goal is. And, you know, STELLA researchers are also looking at how we could use novel AI applications to achieve these goals. And you know, and I want to live with this, and this came from UICC, where someone lives should not determine whether they live. I mean, this is a really sad reflection of where we are, and we have to find solutions. So with this, I want to thank you for listening, and to the STELLA team.
Thank you so much, Manjit. I wanted to ask you quickly just why Linux, and what is better about a LINAC than a cobalt-60 teletherapy unit? I know it's not a quick answer.
There isn't really a quick answer. But the LINAC technology allows much more precision, and May should answer that question actually in terms of how you deliver the treatment, yes. How do you plan the treatment? And one of the big things in our current global challenge is that the old machines of cobalt sources, you know, cobalt machines, there isn't the challenge of security either. Because as soon as you turn the LINAC off, it disappears. And since I'm in VCDNP, I wanted to make that point.
Exactly. So yeah, and for those of you don't know about this ongoing discussion, is that linear accelerators have the added advantage that countries don't have to be concerned about cradle to grave management of radioactive sources. Yeah.
And the only thing, if I may add, is not
Yes.
directly related to the African study, but a recent study we finished was linked to the fact that we looked at similar sort of challenges in all the former Soviet Union countries, because cobalt is their, legacy challenges.
Yeah, yeah.
So not only they don't give the best treatment, and of course they decay with time, so you have to treat longer. It's not as precise because of the challenge of the radio source going down, but also of course being security issues.
Yeah.
Yeah, so this is one of the reasons why we did this collaboration together with also IAEA.
I think it depends on the situation, because what happened in some places where they moved too quickly to Linux and they didn't have the proper infrastructure, they ended up not having any treatment, right? So it's really important to choose the right machine for the right context. And definitely for Linux, you have it goes down deeper, so you get less skin effect for sure. And also the penumbra on the sides is smaller, so you get a more, targeted therapy. But for example, if you're treating bone metastasis in some situations, maybe it won't make that much of a difference. So it depends on the situation and how superficial and the patient's, girth and everything else. But in general, cobalt is easier to use. However, you still have to repatriate the source, and the security issue is an additional issue. With Linux, you don't have to worry about that. But then the process of quality assurance is much more complicated, because you can imagine you don't have an active source. Cobalt, the source is always, there, and you just open the jaws and it goes through, you close the jaws, it's done. With Linux, you actually have to have fine adjustment when the electron hits the tungsten and delivers the X-rays, and so it's a bit more sensitive, but it has many advantages, as you've heard as well.
No, thank you, May. And it's really important. First thing is having access to radiation therapy, whether it's cobalt, whether it's LINAC, whether it's a proton center or carbon center, it depends on what you have. But as we keep talking about skilled workforces, LINACs need more skilled workforces, and they need better imaging and better detection because you have more precision. Absolutely. I mean, ideally, we would all like to have that. Well, actually, we would all like to have a carbon center, but that's a different story.
Okay, so we're going to now move to Dr. Taofeeq Ingrid. He is a distinguished medical physicist and radiation safety expert, so he also knows a lot about it from this angle. And he is a chief consultant physicist and radiation safety advisor and visiting lecturer to medical physics postgraduate programs. He partners with the IAEA on both national and regional projects aimed at strengthening medical physics training, cancer management, and radiation protection in Africa. And additionally, he has served as a WHO consultant and contributed extensively to IAEA publications, book chapters, and peer-reviewed journals. In recognition of his global contribution, Dr. Ingrid was named Fellow of the International Organization for Medical Physics in 2022. Dr. Ingrid, up to you.
Thank you very much. Okay. Thank you very much, Ingrid. This is really wonderful. I mean, when you mentioned this a year and a half ago, thinking how is this, but here we are today, and it took some efforts, but I think it's really worth it and at the end of the day. And I'm really very glad, speaking after May and Manjit, so mine is just to provide some perspective, and thoughts, on the challenges actually, and using my country as a case study, because we really believe if indeed we're able to make a dent to these issues we're talking about in Nigeria, I want to say probably, if not a third, probably a quarter of the situation in Africa should be addressed, So that's the very first slide. I mean, this is from one of our recent publications, 2023, on trying to bring about, trying to see quickly how we can leapfrog. Because if we are not going to leapfrog in Africa, we aren't going to go anywhere, as the situation are. And this has to be data-driven, So, trying to look at the number of radiotherapy and brachytherapy equipment, look at Western Europe, 244, the different parts of Africa. The best we have is just 10 look at the statistics. The other bits of North America, not real North America, you can see that is the, I mean, the other side, you know, because if the America, just like Manjit have just shown, 4,000 Linux, you know, we're looking at 1/10 of that for 340 million, and we're looking at 1.4 billion, you know, so the statistics say itself, yeah. So in a bid to, just like I mentioned, trying to leapfrog, we're trying to look at how best to really move forward in this circumstance. So this table gives a summary of challenges in Type 3 African countries. In our published work 2019, we have 28 African countries with Linux then. Since then, 5 more countries have come on board, making 33 now. The latest being Malawi, which started with a private center last year. I mean, there was I was on an IAEA mission 2022 to Lilongwe, and hopefully, just like the director has mentioned, you know, I mean, the public center is probably going to come on board, you know, this year, courtesy of the Ray of Hope initiative. So this is really wonderful, from 0, and then from 2, and then it moves on. So what did we do here? We have to quickly, again, stratify the challenges. We are looking at countries with less than 1 piece of radiotherapy equipment. I mean, radiotherapy education, the AI, they're trying to, part of the leapfrogging is trying to latch on the artificial intelligence situation now. I mean, looking at machine learning and data learning and all that. Now, lack of human resources, sufficient training or expertise. And then countries with inadequate or reliable funding sources, all these have been mentioned by May and Manjit, you know, earlier. And then especially with respect to the focus of this publication that we're looking at, there's a lot of insufficient data, you know, to train AI models and even the technology and the resources. But where do we actually start? I mean, we try to, I mean, for the 33 African countries, you know, we have put all this together so that this is really going to help us in a way to be able to do this much more scientifically, as it were, you know. So the first thing is actually to introduce the AI education curriculum. That's, you know, because the issues with AI now, legal issues, you know, the training these models that we are talking about. And we need to be very careful here, you know, because we actually want to solve a problem. But if we really don't do it right, a lot of damage, and this is, I mean, the crux of the matter with radiation, actually. Because ab initio, the intention is really to help the patient. But one thing I found in almost my 30 years in this practice is that you can easily do a damage, you know, in a bid to help this patient. So a lot of care, you know, is really required. So we have this as part of the leapfrogging efforts, you know, to have these data that we can actually try to see how to address, you know, the issues, you know, moving forward. So what can we do without IAEA? You know, because this is over the almost like 20 years, you know, several projects. These are regional projects addressing the radiation medicine continuum, you know, nuclear medicine, even now with radiopharmacy, you know, I mean, the concentration earlier on used to be radiotherapy, medical physics, you know, and now nuclear medicine is taking, I mean, a lot of ascendancy with radiopharmacy, you know. In fact, at a point, again, there was a diagnostic radiology bit, you know. So we can't really thank IAEA enough. So on behalf of the African countries, I want to ask May to convey our gratitude, as usual, always, to the Director General of IAEA for all the support. And you can see from May's slides again, with respect to this pillar of Ray of Hope initiative, a number of African countries are actually taking benefits, you know, from this initiative. And we hope we can actually benefit more. I know that the DG was in Nigeria last year. It was a very big fanfare with our First Lady. And we are looking forward to taking benefits, you know, from this initiative, just like it has happened, you know, with the other countries earlier mentioned on by May. So now looking at my country, you know, as a case study, because just like I mentioned, I mean, with the huge population, in Nigeria, we believe, at least if we're able to get it right and then probably do something impactful, in Nigeria, at least 25%, without any doubt of situation in Africa, we want to believe grow. And then, like His Excellency mentioned, as we are coming in, that Nigeria, big brother Nigeria,
Yeah.
So Excellency from Burkina Faso, so we really want to see how best to really do this. So I want to present some quick real statistics, So this is a map showing location of existing cancer centers in Nigeria. Right now, as we speak, for a population of over 200 million, what exactly are we talking about? Just 15. 15 cancer centers. It's abysmal. I hate to present this, but what can I do? I mean, that's the situation. Perhaps that's really going to ginger us more. Okay, so we have a new, it is just like I'm going to show in my subsequent slide, the profile. Nigeria is that we have federal government projects, a number of state projects are coming up now, but the model that is really catching the fire now is the PPP, just like I was telling Dr. May a short while ago, because most of these governmental facilities, unfortunately, you hear of 1 week downtime, 2 week downtime. I don't know what you want to talk about 6 months. Is that a downtime too? And this is a situation, we find in most of our, in fact, out of these 15 centers that I mentioned, 8 belongs to the federal government, and as we speak, there are no functional external beam radiotherapy in half of this. And that's a sad reality. And these are really very big institutions that you expect, most of the patients will have to go into. So at least luckily, a new one just came up in the North Center now. You see, Kano, with 2, although it has been lying fallow for like almost a year and a half, but at least by October last year, some activity is going on now. We hope it catches fire, permit my use of language, quickly. Sokoto used to be a flagship because I remember 2012, that's where we started our medical physics residency program because the Linux were just installed fresh, that time. But unfortunately, as most of the governmental thing, it went down to 0. Again, not functional for like 3 years. But luckily now, I think probably a queue has been taken. A new Linux is now installed, and I'm really, really very glad to see what is going on in Sokoto. The management of Sokoto will have to really have to bring in some private people to really get this. And it's making a lot of sense, just like I was telling Dr. May too. Sokoto came up with an initiative now that a federal government institution, that they're able to even treat pediatric patients now free in our situation. I think this is commendable, Unfortunately, again, the other center on the other side, probably you must have, it was in the big news, had 2 big machines and with 2 brachy, that's the only facility that actually has 2 brachy in the country. Unfortunately, there was a disaster last year, a flooding, that has knocked off that center now for like 6 months. A concerted effort is being made now to really bring it on board again. And then luckily, the centers, that we have, the private and the private-public partnership are really doing well. And I think probably the government is trying to latch on that with the new initiative that is coming up, that we have the Nigeria Sovereign Investment Authority, which is actually having the flagship radiotherapy institution, in the country now, with 3 Linux, so to say, 2 Vital Beam and Alcyon, and with 10-year service contract. I mean, this has been one of the overarching issues, all this. So with 10-year service contracts, you can be doubly sure there will be no downtime. And in any case, the pressure is on the other side now to really make this work, and there hasn't been really, downtime and Lagos. This is a very huge center. There are some other 2 private facilities, but we aren't really getting it. So this is the name of the facilities, like I did mention. This my former place, the National Hospital, used to be a flagship, the Linux, and then we have a cobalt-60 atrial brachytherapy now, but more often than not, a lot of downtime here and there. Maiduguri, like I mentioned, has been off like 6 months because of this flooding incident now. A new one, I mean, having learned from what's happened, is this Sokoto that I did mention, in the very remote part of the country. I remember what the CEO used to say there, that there's only 5% of people from here that can really access this service. Just 5%. Okay, all right, okay, thank you. So the state government started, there's the one I said started about 6 months ago, and then the PPP, the flagship is this NLCC, and then the new one that's come up in Ebonyi. Now, those are the private facilities. You really didn't heard of any serious downtime in these facilities. And then look at the proposed sites. We have 15, but about 10 is coming up again in different ways now. I mean, the government is trying its bit, like for looking like mid-year, some 3 more centers are supposed to come on board. And so those are the private facilities and the PPP in the country. We're doing something, a publication on this, which should be coming up very soon, and thank you. I think probably this is just my quick submission. Thank you.
Thank you so much. And so you've wonderfully laid the ground for Dr. Sam Thenya, who is in the business of finding solutions. He is a renowned medical doctor and entrepreneur, and he's serving as the founder and group CEO of Nairobi Women's Hospital, the NWH Group, which specializes in obstetrics and gynecological services. The NWH is one of the largest private hospital chains, in East and Central Africa, boasting a 576-bed capacity and operating 8 fully fledged hospitals. The group also includes the pioneering Gender Violence Recovery Center, offering prevention, treatment, and psychosocial support for survivors of gender-based violence in Kenya, as well as the NWH Medical Training College, which has trained over 30,000 students in mid-level medical courses such as nursing, laboratory sciences, and clinical practices. Under Dr. Thenya's leadership, NWH has experienced significant growth, bolstered by investments from international private equity firms, marking one of the largest foreign direct investments in local healthcare company. Beyond healthcare, Dr. Thenya was recently appointed by Kenya's president as vice chair of the Technical Working Group on Gender Violence and Femicide, further solidifying his commitment to addressing critical social and medical issues in this region. Sam, can you give us some hope?
All right, thank you, Ingrid. And I thought we've looked at the screen enough, so we can look at each other and dialogue a bit more. So my perspectives will be basically on Kenya. I'll try and generalize on what could be and what it is in Africa. I think sometimes people assume Africa is a country. But Africa is a continent. So when you come and talk about challenges in Africa, it becomes very difficult to generalize because these countries are very diverse in many ways. So I'll just cut the chase and say that Africa, and especially Kenya, is not lacking in policies. So even with what you're talking about here, we have the Kenya Cancer Policy, we have the health policy, we have the National Cancer Control Strategy. All these are there in Kenya and in other African countries. However, even after the policies, there are very many other initiatives, and you can see them. And what surprises all of us, and many of us, is that cancer screening, diagnosis, treatment, and other medical services have become like a moving target. It's like this mirage that everybody's chasing. And I think one of the biggest mistakes we make in Africa is to try and copy what has happened in the developed countries. There's not a single healthcare system in the world that I know of that is perfect. In fact, everybody is always trying to look for the next best healthcare system. So why would we want to copy systems that are not working? And the moment you copy, you find that something else has moved. So having said that, then for us Africans, we really have to think on our own. We're basically on our own, my brother, because there's no system. And I find people going for benchmarking trips, politicians, I'm sure some of them are here. They come for benchmarking missions. Yet Africa has to find its own solution. So I think the role of radiation treatment has been mentioned. I don't want to get into that. So one of the things that I tell people is that getting a disease is free, but preventing, making a diagnosis and treatment is not free. So let's start with the prevention, including cancer. So if 40% of the cancers or so, I'm not an oncologist, are preventable. So what does it take? For every citizen, whether in Africa or wherever, you have to invest time to get fit. You need to invest in living healthy. You need to invest time in, of course, stop drinking, stop smoking. There's a cost to it at an individual level. So let's park that. Other preventive measures that, especially in Africa, we need to do, like, just a clean environment, pollution and all that. It takes some resources. Awareness. Do people even know that they can prevent these cancers? Strategic communication. It takes some resources, but prevention is cheaper than treatment. So all this cost money. So getting the disease is free, preventing, diagnosis, and treatment is not. So having said that, let me go to the barriers that limit access. So obviously then, therefore, because diseases are free, prevention and diagnosis, including early detection, which is part of the prevention, screening is part of the prevention, and then treatment, all these require some resources. What has happened in Africa is that we've relied mainly on governments. Now, when you look at the developed world, when the developed countries were investing in, for example, in healthcare infrastructure, when you look at the cost then and the cost today, it's very different. Number two, when we look at us Africans, when you want to buy a CT scan, $300,000, a PET scan, $500,000, a linear accelerator, $500,000, it is in dollars. It's not in Kenya shillings or any other local currency. And that is very expensive for Africans. So there's a bit of discrepancy, even in terms of how Africans can access this equipment that we are discussing here. So you find that then, therefore, governments in Africa are also faced with, number one, limited incomes, therefore less taxable incomes, and with all these other myriad of things that they must invest in. And you find that then cancer becomes at the tail end of investment because people are dying from lack of clean water and other things that we all know about. I don't want to sound like prophet of doom, but that is the reality, that even screening programs are basically funded by donors, not by taxpayers in most of African countries. Therefore, my proposal and my stand is that what Africa needs is healthcare investments into the private sector, but also probably also into government. But there's a problem with government sometimes, and especially African governments, but I think most governments, is corruption. So you find that if the resources in Africa, and especially, let me say in Kenya, were directed properly, we'll probably have more equipment, we'll probably have better detection, we'll invest more in our communication, creating awareness, creating facilities, even just for people to have places even to just walk around, exercise, some security so you can walk in the evening after work. In most of the African cities, after lights out, it's dark. So even just the cost of energy, which also is required for this, to run this equipment, is very prohibitive. So you may even have a donation of an equipment by whoever wants to donate the equipment. And this is why they keep breaking down. Then you don't have the resources to buy spare parts. You don't have the money for servicing that equipment. You don't even have the power in some of the places. I do know of a program that brought quite a bit of equipment into Kenya. But in the places they were installed, there was no electricity. So how are they expecting to run this equipment? There were no specialists. In Kenya, there are only 3 pharmacoradiologists. Radiopharmacists. 3. So how do you expect this equipment to run? There are no specialists to use it. So my suggestion is that what Africa needs, whether it's for cancer or for healthcare, is we need to look at PPPs. And I'm glad my brother here has mentioned about PPPs. PPPs is where private investment would meet this public need. But beyond PPPs, private investments, including DFIs, private equity, they do help accelerate access to general healthcare and especially also to cancer. And this is where the money needs to go to. And unfortunately, now just to go into where we are currently and where we are going, is that private equity and DFI is actually disinvesting in private healthcare in Africa. I'm one of the, I can say as a case study, where my investors, whereas it's been said they have got all these investors, they just couldn't continue investing in Africa, and I'll come to the challenge. So I have to then buy them out. So my capital then went back to the previous investors, of course, with a greater return and out of the country. Why? Because the system of healthcare reimbursement in Africa is completely in shambles in most of the countries. Whereas we committed to universal health coverage, we all know about the Abuja Declaration, it has not worked. And you find that, for example, in Kenya, we had the National Health Insurance. It was a bad system. It was replaced with a very good idea, which was the social health insurance, very badly implemented with a lot of corruption and other attendant issues, and therefore is worse than the previous National Health Insurance. And so for an investor, you see, money must get a return, whether it is, she was talking about investing some $billion so that we can get $1 trillion of return. So every amount of money invested must have a return. So when you look at these investments coming or that could come to set up this equipment, if there's nobody to pay for it, then why would an investor take their money? And even the donors, this is what we need to remember. And I think sometimes, with a lot of respect to NGOs, we forget that this money being given to NGOs and even to countries is actually other people's money. This is money that you in the developed countries and other developed countries were taxed and is being given to corrupt officials and being wasted in the name of giving opportunities for healthcare in Africa. That is not going to be sustainable, and it is not sustainable. So my suggestion is that the only way to get us out of all this is proper healthcare investments that have proper governance controls, and this is where the private sector comes in. Let me just, maybe so that I don't take too much time and we have a bit of time, is then to just suggest that one of the things we need to do is also to activate political goodwill in Africa. and proper governance. I think that is a given. Attract this private investment into healthcare infrastructure. And this goes towards even the equipment, the energy I spoke about. So for example, if you're going to put whatever equipment out there where there's no electricity, invest in a windmill, in solar, or whatever electricity, so that then there's a backup that goes with it. And some of the other innovative ways of financing healthcare could be bonds, healthcare bonds. African governments are very good at raising infrastructure bonds for the roads and everything else. One of the innovative ways of solving this could be a cancer board, for example, that raises money, and then if that kind of the return that is you're looking at, this could be a very good thing, even just globally. When it comes to lack of specialists, because this is not just in cancer treatment or in oncology, one of the ways that we can help each other, and we actually do collaborate globally, is through research. I think that has been mentioned. Using technology now, we do webinars, we collaborate, and I think the world is becoming a better place with technology. And when we leverage on this technology, so we're able to consult on difficult cases for diagnosis across the globe, and this is becoming much easier. So we may not have to invest in all these specialists. I saw the time it takes to train them. Some of them could also be helping us remotely. And this is where Africa needs to look at how do we solve these problems using the current technology and not trying to do what was being done in the developed countries in 1930s, because that ship sailed a long time ago. I think I've said too much, some of it controversial, but my thinking is that, and my suggestion is that private healthcare is the way to go. We at Nairobi Women's Hospital have been able to do that. I started with one small hospital, 29 beds, 24 years ago when I was a young gynecologist, and went up to 8 hospitals now. We have a gender violence recovery center. We provide free services for GBV. I guess that's why the president decided to appoint me into the task force. And we also have a medical training college. Currently have 3,000 students there. And this is all private investments that makes a difference. Does it have a return? Of course it has a return. And should it have a return? Yes. And one of the things, allow me to just say that, is that, there's a lot of activism against private healthcare investments. I do know, I don't suggest some of them, I do know some of them are changing policy as we speak against investing in healthcare and education because of global activism against private healthcare investments. And this is very dangerous in that, whereas, people have this thinking that you're profiteering from other people's misfortunes. So would you rather they die from those misfortunes? Would you rather then invest and get a return and they get well? Because then what is the return on them getting well and then their productivity? These are the kind of conversation we need to have. And probably we need to have another session on how do we finance healthcare in Africa. Thank you very much.
Thank you. I think before, thank you so much for that. And before we turn to the audience, I just want a quick response, perhaps, if I can ask May. The IAEA provides support to its 178 member states, and the money that is coming through the IAEA, I've heard recently people refer to that as the IAEA being very wealthy and having a lot of money. But this money, of course, comes from its member states. And you pointed out, May, and the amazing support that the IAEA gives to the member states, and the research and development that it does, and the way that it moves us forward, globally on these issues. But you also mentioned that 93 countries have asked for support under the Raise Up Hope initiative. Where is there enough money coming through from IAEA budget to fund that? or because I know the Director General of the IAEA also has made, and this is part of the Raise Hope initiative, as far as I know, is this trying to attract other investment outside of the usual government investment. Can you tell us a bit more about that?
Okay, so that's a very accurate statement that there's quite a few countries that are requesting support. And obviously, Raise of Hope is an extra budgetary project, meaning that we raise money to be able to support the countries. So raising money could be from traditional donors, member states. It could be from industry. So we've done a lot of interaction with industry for also in-kind contributions and things like that. But also working with banks, especially development banks, to be able to either have loans or in some cases grants, it depends on the situation, to be able to support some of these activities that are happening on the ground. So there are many different, pieces of the puzzle. So the colleague mentioned, public-private partnership is the way to go. It is very important to encourage that as part of the puzzle. It can't be everything, but it has to be part of the puzzle. There are advantages, disadvantages. There are, access issues in some cases. So we have to really have a combination of solutions. There's not one solution fits all. So in other words, specifically for Raise of Hope, we have been doing it in a stepwise manner. The countries that I showed were like the first wave of countries, we call them. And then when we finish that, we go to the next one and the next one. So it is a process of raising funds for a very good cause, obviously. And we have several different pockets, so to speak, that we use. Also for the loans, we support the development of these bankable documents to be able to go and train people how to do them and all that. So there are different things that are being done to allow all of this to happen.
Okay.
So does that answer your question?
Yes, thank you. And I think one of the things that I find that in the discussion that we've had is also the importance of creating awareness about the economic impact of cancer in countries, and then on return on investment, as you've said, Sam. Without that understanding, we need more of that in governments and with the private sector to understand that this is a good business from a political and from a business point of view. So let's open the question.
Can I just say
Yes,
something there?
absolutely.
Yeah. You see, I think we need to really think about, and I'm not sure what you fund. Are we funding inputs or outputs? So the funding for inputs, for example, in governments is where they get equipment, they get all this infrastructure, and then it's no longer sustainable. And that could be a problem. And this is what I'm trying to say, that governments need to look for innovative ways, put money where, and this is where the limitation of access would then not be a problem, because investments will go into the inputs, then find a way of funding the output. For example, once you do this kind of screening, this is what you get paid. It doesn't matter whether you're in the private sector, whether you're in a state facility, whether in a faith-based or national facility. So then the patients also have a choice, because sometimes even in those government hospitals, it becomes very difficult to even have that access because of the crowding, the quality of care. The staff are demoralized, and that's a truth, and that's a truth of the matter. So you may find, and we do have in Kenya very good public hospitals, actually some of them better than my hospitals, but people don't want to go there because of just even the experience when they go there. So this is where we need to address.
But how do people fund? How do people pay for services if they don't have money?
So this is where the universal health coverage comes in, where government should be able to pay for those who cannot afford to pay. It's the financing mechanism for the outputs that we need to focus on. It will attract the investments, whether they're in public or whether they're in government. Because at the end of the day, somebody has to pay for it. And I think that is a big question that we don't address. Who's going to pay for that person who cannot afford to pay? And that's what the governments need to focus on. Exactly. The same thing as education, even if you put all these classrooms up, there's a current cost that goes to it. So who pays the teacher, who's going to do what, where the book's going to come from? That's what needs to be addressed even in healthcare.
Comprehensive plan has to be done from the beginning. So when we approach a specific project, we have a comprehensive plan looking at the workforce, and if that's needed, then it has to be put in, looking at maintenance, advising the country of the need for maintenance contracts and how long, all of these things, and choosing the right equipment for the place so that it functions easier. We even look at whether or not the accessibility to parts and accessibility to in-country support. All of these things are taken into consideration when we actually go and procure and we train. So it has to be really a comprehensive view of how to do things rather than just one. And then just mention very quickly on the public versus private. There are many good public hospitals. We understand that it's becoming harder for them. It coincides with the governments and the money is coming in. But we do have studies showing that like in breast cancer, there could be better survivals in some cases. So what I'm trying to say is it has to be looked at individually rather than just saying public and private, because it depends on the institution, on the people there, and also the payment mechanism.
There's no free lunch, free time.
No free lunch, no free lunch.
And what we've also seen is how political leadership is also very important. I think, and we've spoken about that before, is that if you have a country where the president or the president's wife takes it very seriously, then you have a better chance of getting more political commitment to cancer.
Yes, absolutely. And even the budgetary allocations, once the political, as I said, the political will
is there,
the focus is there.
The
budget changes. Yeah.
Good. Is there anyone here who would like to ask a question, make a comment? Yes, Ambassador.
Yeah, thank you.
Oh, wait. We just have to get the... Sorry. So that our online audience can hear you as well.
Good afternoon. Thank you. My name is Maimunata Ouattara. I am Ambassador, Permanent Representative of Burkina Faso here in Vienna. Thank you for giving us the opportunity to learn more about the cancer care for all. And I have learned a lot. It's very informative with high-profile professional experts sharing their views. They are all complementary, to me say. It's true, I say that Africa is not one, and we have specificity, but this, whatever challenge or solution has been proposed here fits each African countries. And the case study, both on Nigeria and Kenya, speaks to all the countries, maybe low-income countries beyond Africa. And IAEA is doing a lot. What we need, as you have said here, is the political will. What do you want? Which society do we want? What kind of people we want for the country? How do we see the world? This is very important. Those are, I think, just personal questions and the policy question we should ask ourselves. And I have been very, let's say, I was in myriad of reflections, not knowing how do we do this. I don't want to be discouraged by the immensity of the challenges. I'm looking for solutions, and you have thought of, she mentioned these novel solutions. I loved this word, and you are discussing the way forward. The way forward, I agree it has to go with the political will, but it's, I don't know if nowadays at the global stage, what is the political will? We need a definition of that, because we are not, it's not easy to look at in the same direction, but we are going kind of apart. As people here in the room, I have been asking, questioning myself, what should I do? How can I do to change this? It's a matter of funding, it's true, but it's not all a matter of funding. I was thinking of something that Raise of Vote, as Dr. Taofeeq mentioned, was a chance for some many African countries and other low-income countries. Burkina Faso had only half radiotherapy center. Half, I say, because you start a process and you go to Mali. That's why also I have seen a solution that we can mutualize what we have, the experts, the equipment. This can help. Now that we are having machines, maybe to put Raise of Vote continuation, maybe to put together a network of machines and expertise, a pools that can support each other. We know it's difficult. In Africa, for example, when we are sick, we don't go to hotels. We look for, oh, do you have a friend in this city or a family member where I can stay for the treatment? So to talk, my proposal is that we look at indigenous solutions. Yeah, so that's what I would like to propose here. Go to the communities, talk to them. What are the solutions you are thinking? Not us thinking for them, because there are solutions by culture, by, I don't know, in Africa, we have solidarity. We can see how to do it. When there is a war or a crisis, we are able to host the internal displaced people. We can do that also for our people in need. Thank you.
Thank you. Yes, Manjit. Oh, you can just talk.
Oh, sorry.
Yeah.
Yes. So, no, thank you, Ambassador. So actually, I absolutely agree with the fact of the.
You have the mic.
No, it apparently works too.
Yeah.
I don't know, but I think it works. Anyway, just to say, I absolutely agree with the idea that the solutions we look for have to be adapted to the environment where we are looking at. And that's why I said we have to understand the challenges are not the only things our LMIC countries bring. They also have to be part of the solution and their ideas. And coming to this PPs and government facilities, this is why with Taofeeq and other colleagues in Nigeria, we first looked at all the government facilities in Nigeria and see what the challenges were. And now we are basically at the point of have looked at the PPs to see how they differ, what are the challenges, and what do we learn from this to move on. So that's exactly why we start with Nigeria, because I happen to be very fortunate that I have colleagues in Nigeria, but also it's the largest country and it has very few machines, and we wanted to see the differences. I mean, instinctively, you might think PPs are better, but you have to have the data. You know, I'm a data-driven person, so just to say, I absolutely agree with your comments.
Is there anyone else who has a comment or a question in the room? Tony, do we have anyone online? Yeah.
Yeah, let me just get them out. There's quite a few questions, comments.
So one of the questions was related to the training and the harmonized training period, and how could that be implemented in Africa to get harmonized training? There's a view that as you train, people then leave for greener pastures, so it's not sustainable.
Do you want to ask a couple more questions? So
yeah, and then another question is, to what extent do the regulatory bodies, the radiation protection radiological bodies in Africa, help or hinder with the creation and operations of centers? Are they suitably equipped to support these activities? And can they build public confidence in the safety of the facilities? And then perhaps another set of questions, is cancer curable? And what determines whether surgery or chemotherapy or radiotherapy is the solution? Can men get breast cancer? for example, and then the spare parts issue and the qualified specialized staffing issues, how could those get resolved? Do you have any thoughts of how that could be addressed?
Okay. So let's start with Taofeeq.
All right, thank you very much, Ingrid. Where do we start from now? All right, so I have so many questions. Yeah, that's right, but I think perhaps the question of the length of training, because I remember when we were starting off with the IAEA supported country projects. By the way, I forgot to mention the fact that those slides I put are regional assistance, from the agency. There are some country-specific, projects, that the IAEA is helping with, So when there was this accentuation of cancer centers, in the country, way back then we find out there's shortage of some certain key professionals, especially the medical physicists. I mean, in a particular center, we have the radiation oncologists, we have the radiographers, but then the machines then were designed because of the power infrastructure, to run on diesel for 24 hours. Unfortunately, the bigger gen during the day when the machine is, because the configuration of the machine is that there's a vacuum that needs to be kept. So during the night, this small gen, will run. So like 24/7. And here we are, we have some group of professionals, you have the burning diesel, and yet you are still, and the patients are still dying, So who are these medical physicists? So with the help of the IAEA then, of course, we started, May actually mentioned those curriculum. Probably they are very, have been prepared by the agency. But the number of years that it will take, to make this is becoming a disincentive of some sort. So the agency, again, there has to be a small project, that was designed, targeted, for Africa.
But we are depending a lot on the agency for a lot of things, right?
That's right.
So
unfortunately.
So how do we shorten the time that we use online training? What do we do? How do we do that?
So there are two aspects to the training that we have to consider. The first aspect is the initial training when you're creating a person, specialist, almost like. And that one, as I said, has changed over time. So can we shorten it? Possibly, but it has to be done in a very well-studied way, probably with data within a research study to see the outcome and to be specific to what can be done versus just a time frame, right? So that can be done, and it's, in my opinion, and this is, not agreed by everyone, I'm sure, but I think we can be more efficient. Many people spend time wasted during the day where they could be learning something new. And I think the use of certain tools, right now we have a new virtual reality module, well, a couple that show you how to do the implant and set up on a machine. Well, I mean, if people use those first, then the next step when they do the clinical part maybe won't take as long because they've already trained on something like that. And it's not a new idea. Surgeons are already doing it, right? So that could be it, but it has to be done in a way that's very systematic and data-driven. Then the second phase is continuing medical education. Continuing medical education has to be access to many of the tools that I've shown, and it has to be assessed to see that it's effective as well. So I think those are the two things. And the last point I want to make is why train people if they're going to leave? Well, one of the things we try to do is that people, once they finish their training, at least the IAEA fellows, would have a place already set for them. In a center that's functioning. Because if you have a professional that you've trained for, I don't know how many years, and they go to a center that's not working, well, I mean, if any one of us would not want to stay, because then you lose your whatever you learned. So I think there's a responsibility to make sure that the people we train have a place to go back to as well. And then things can work out. But it's multifaceted, many different areas that you have to address.
Yeah, could I just
Yes.
comment on the training? You see, and I do agree on what now it comes to what are we training for? We are training a resource for that country. It doesn't matter where they work. And I think that's again what we need to rethink. So if you have several centers, then you can train one person who can manage across centers. And as she's rightly says, you know, some of the government centers are not working. And you find these highly specialized people very frustrated because they have trained, they are committed, they really want to help. But every day when they go there, there's not this, there's not that, there's not this. And they're not happy doing that. So that's why they leave. But if there are other centers that are working like private sector, they can also practice there. So this is a kind of collaboration. And it actually happens whether you like it or not, even without any structure. We have doctors who are trained, highly trained, but they are trained by the public sector and they work with us. And that's okay because we are serving the same population, you know, and they earn a little more. So then they have no desire to move out of the country because at least their level and, you know, the government may not be able to pay them a certain level of salary, but they can add some more in the private sector. But this is a resource for the country, not for the public sector. So, yeah.
Model that you're talking about, there should be some payback from the private sector to the education of these people, because it costs a lot. We underestimate the cost of human capacity building. It's huge. It's almost equal to the machines. And if the government, if not more, so if the government is investing public dollars into that, there has to be some investment from the private sector in the education of these as well. And then the model that you very adequately explained would work beautifully. But what we don't want is whether they leave the country or they stay in the country but go to private sector, which may or may not be open access to everybody, right? Because it depends on the government. Some governments, they're able to negotiate and universal health coverage, anyone can go anywhere, okay, then it doesn't matter. But in some situations, you end up with only people who are able to pay that are able to go to these private centers. And you might have a lot of centers in the country, but the access is not there. Well, we were talking about geographic and financial access.
Yeah, but sorry, but let me also tell you, you see, we also have to rethink this. You see, a while ago when I was training, that's like 30 years ago, there was only very specialized center at the Kenyatta National Hospital, which is like the national referral center. So what happens is that when there's a queue for radiotherapy, it's actually then the rich who access it. Because, you know, they know who's who, these senior doctors and everything else. When the private, those who can afford, when they go to the private hospitals, it gives access actually. So let's not always think that people going to the private hospitals,
Money.
When people go to private hospitals, we're actually doing government work. We are decongesting the public hospitals.
But they have money, right?
Wait, they can't hear you online. They can't hear you online.
So that's the reality of things.
Dr. Sam, we are discussing something that is actually happening and is beyond all of us. In Burkina Faso, she said it's something, I want to give an example. We trained some medical doctors, some specialists, and the center were not ready and they left the country.
Understandably.
You understand? This is not even between private and public. They just left the country. Let us think creatively how to have the people at the right place. Thank you.
Okay, this is a fascinating conversation. We can go on for hours, but we are running out of time. We're actually over time already. So I just quickly want to focus on the radiation bodies, whether they hinder or support, and who can talk to this briefly.
Mostly our nuclear safety colleagues would be involved in the regulatory part, but basically there is training for regulatory through the IAEA and many courses. And when done right, regulatory should not hinder, but actually help. It provides support for safety. It provides advice on the ground. And it's really important to regulate and make sure that the product that comes out is what we expect it to be. So that's regulatory. Now, if the education is not there, then we have a problem. And that's not only in LMICs, it's all over the world.
Anyone
Anyone who's practiced has come across that. And I think that the second thing is, of course, for safety that you mentioned, we have to remember that safety is not just the regulatory. Safety has to be proper training of physicists, proper, workflow, many other things. So safety is a kind of joint function.
Exactly. And then I think in terms of also what Maimuna has said, the regional approaches, and I think that's one of the areas where this challenge with spare parts has been, there are attempts to address that in a regional approach, and to see how spare parts can be held regionally, how one can involve private sector to be more involved in that regard. But there are various opportunities that are presenting themselves. And I think we're getting to the end now. No more questions. If there's one more question. Okay, one more question.
It's not really a question. It's there's quite a few comments from Japan offering assistance and interested in how the university, I'm just trying to get the name again, the Jutenda University can help. So we'll give those questions to the IAEA. See.
Oh, that's fantastic.
And then just a comment from Mongolia, where PET CT has been installed at the university, and they're saying thank you.
It works really. Thanks to the IAEA.
Thanks to the IAEA. Rays of Hope, Government of Korea, Government of Mongolia obviously helped. Previously, they had to go outside the country to get imaging done. So
it's fantastic. Yes, I mean, what the IAEA does is there is unbelievable in terms of its support on regulatory level, on providing all of the support that May has told us about. So I'm going to turn to our panel for closing comments, and we'll start with you, May, and just a short reflection of solutions. Where do we go from here? What do you need as the IAEA?
So we have a lot of partners already that we're working with, and the Japanese colleague, we have an anchor center in Japan that consists of 16 universities that are already supporting Rays of Hope through the anchor center. So that's happening. I think each one around the table has a function and can support the mission, whether it's in education or equipment or otherwise. So what I would say is the most important thing is to coordinate all of these activities and be able to work together towards a common goal.
Thank you.
Very short and sweet.
Manjit.
So following on from me, I was going to say it's clear that whichever challenge you look at, here we're looking at cancer, is a multifaceted problem. This is a multifaceted solution. And of course, money is not everything, but it helps a lot.
Okay, thank you very much. Probably giving the specific example, probably from my country, I think it needs to be said, some of the efforts, that the government have put in place, like latching on the best global practices, that's a National Institute of Cancer Research and Treatment now that has been instituted by government. And with that, coupled with the some synergy with the regulatory authorities, and then the Atomic Energy Commission, this collaboration goes a very long way, to really make things happen, and this should be encouraged. Thank you.
Some final thoughts.
Yeah, for me is that number one, Africa needs to rethink strategy and more collaboration. So you may find, for example, what we are saying about spare parts. Those 400 machines are probably 20 different types. So the spare parts may not even be the same. So Africa needs to rethink, do we just get a certain supplier or two, then this is the way to go. And therefore, then you can talk about spare parts and aggregation. It also helps in training because then people are trained in using the same machine. So we just need to think our strategy of how we do this. The second one is obviously, as she said, money is important, very important. But it must also be directed to the right places for maximum effect. And finally is not just political will, is governance. The governance structures need to completely improve. if we are going to be able to sort out the healthcare and cancer issues in Africa.
I see Manjit wants to say
I
something.
wanted to just say something to Sam.
Yes.
I think how the money is directed and who decides how the money is directed and what is used for, those processes are the most critical. And this is where not just Africa, but certainly our LMICs really suffer from.
Yes. Yeah. Agreed.
Yeah, thank you so much. And I think one of the things that I take from this is we need, and this is one of the reasons we do these panel discussions, and is to raise more awareness about what the IAEA is doing, what the challenges are we face, but also what is out there and what are the solutions already. And we very rarely hear from private sector, and it's important that we collaborate more with private sector, that there is a stronger engagement so that we can all learn from each other. And I really appreciate the time you've taken to come to this meeting, to the panel discussion, for you who have taken time to fly here from all over and come and share this information with us. And for all of our online participants, please remember to fill in our form, evaluation form. It helps us a lot. And we look forward to seeing you again in the near future. Let's give everyone a hand job.